Thank you naman at nakaikot tayo dito. Ang ganda ng lugar.
No, ang ganda talaga makikita. Ngayon na tayo nakapasok.
Mas na-appreciate ko siya kasi the first time I was here, maraming tao.
During the inauguration,
Yes.
no? I think this was inaugurated noong September 20.
Yeah.
Tama?
Eh, ano yung January daw?
Parang soft opening yan.
So,
Yes, the open days. Tapos pero yung formal inauguration happened.
ayaw may piya kayo tayo ngayong September.
Yeah, wala tayong idea na yung class project pala natin ganito kaganda.
Yeah.
Kasi we contributed to this.
At least ganito, no? You know where your money went.
Tsaka napakaganda kasi it's something na hindi natin na-experience.
This is something new, groundbreaking for the
Innovative. I mean, it's a new way of teaching, so it challenges us, the faculty, also to learn at the same time, so be learners also with our students.
Paano ba tayo natuto ng skills? Sige nga, paano?
Sa tao na
So one, do one, and teach one.
Sa actual person.
Yeah.
Samantalang dito, pwede na nilang practicein yung skills sa mga mannequins na ang gaganda.
So yung refinement, yung analytic techniques, yeah.
So lesser
Very
ang
nice.
possibility of injuries.
morbidity.
Kaya nga, actually, nung nalaman ko na pang clinical simulation lab yung project natin, I was really very happy na it turns out na napakaganda ng makakontribute natin sa college.
Alright, so Leonard, we came from the OR setup now. So here, we're in the task trainers room where students can practice already the different procedures like IV insertion, breast examination, blood extraction, and also pelvic exam and catheterization.
May circumcision din.
Ayun, nandun yung
Yes.
circumcision.
O di ba?
Yeah.
Nahirapan ka nga dun sa retroverted, ano?
Yeah, nung tinry ko kanina, muntik pa ako mapahiya.
So yeah, so aside from that, there's also a childbirth sim area where patients can, let's go over there.
Okay. Ito yung favorite room ko out of all the simulation rooms kasi this is the OB room. And ito si Lucina, the model for the normal delivery, right? At ito yung baby niya. May pangalan ba yung baby niya?
Wala, Lucina, baby.
Bigger.
Ang galing, no? The students can actually
Gumagalaw ang patara yan!
They can actually simulate childbirth dito. No?
Yeah.
And all the other drills.
All the maneuvers like shoulder dystocia, do vacuum extraction,
Breech
forceps.
delivery.
Yeah.
So for both normal and abnormal situations, emergency.
Yeah.
Yeah, so they'll ask the professors, the doctors to give a scenario that they want simulated. So they also have modules for postpartum hemorrhage, for uterine atony and uterine inversion. So yeah.
Tapos yung SimTech, i-input nila yan dun sa computer. Tapos yun ang gagawin ng
Kailangan the consultant should be very detailed para alam ng mga bata kung how to approach these emergencies or whatever.
Pero kahit face-to-face tayo ngayon, mas magandang dito na muna magsimula, di ba? Para parang magaling na sila pagpunta nila sa PGH.
May skills pagdating sa
Equipped with the skill.
True.
Hindi natin to magagawa without the help of our classmates
True.
who generously gave to this project. Even if we had the slightest idea of what the thing we're supporting was at that time, di ba? And moving, as you said, from that medicine building to the Henry C. Medical Sciences Center and to the CSL finally. And we look forward to celebrating with the rest of our classmates for our homecoming this year and celebrating also this achievement of being able to help and give back to the college. Maraming salamat.
Nilulat ang mata sa katotohanan, Pinukaw ang damdamin para sa mga aba. Galing ay nilinay, talino at kakayahan, hanggang sa maging mahusay na manggagamot ng bayan. Itanghal ang ating pinagmulan, pagpupugas sa kolehiyong mahal, paggunita sa ating pinagdaanan, UP Medicina babalikan. May nanibang bansa at doon ay namilahan, ang iba ay nanatili sa sariling bayan. Saan pa man naroon ay pinagbubutihan, dalaman na pangalan, pamantasan na hinirang. Itanghal ang ating pinagmulan, pagpupugas sa kolehiyong mahal, paggunita sa ating pinagdaanan, UP Medicina babalikan. Itanghal ang ating pinagmulan, pagpupugay sa kolehiyong mahal, paggunita sa ating pinagdaanan, UP Medicina babalikan. Paggunita sa ating pinagdaanan, UP Medicina babalikan.
Pagpupugay at paggunita.
Pagpupugay at paggunita.
Pagpupugay at paggunita.
Pagpupugay at paggunita.
Panginoong Diyos, inaalay namin sa iyo ang 2024 bilang taon ng aming pagpupugay at paggunita.
Naway maging pagpupugay sa UP College of Medicine.
Ang lahat ng aming hinandang pagtitipon at pagkikita-kita. Kasama na ang iba pang aktibidad katulad ng webinars at postgraduate courses.
Sa aming paggunita at pagpapasalamat sa kolehiyong mahal.
Ugawin mo ang aming puso at isipan na handang tumugon
upang mapagsilbihan ang lahat ng nangangailangan
at may sakatuparan ang aming kagustuhan at hangarin.
na makapaglunsad ng mga proyektong pamamayanan.
Bigyan niyo po kami ng oras, kakayanan at kagustuhan
Na makilahok sa mga gawaing itinakda sa pinagpalang taon na ito.
Isinasamo namin sa iyo na maging matagumpay.
Makabuluhan, kapag-ipakinabang at masaya.
Ang lahat ng mga aktibidad ang mas katugmasa para sa taong 2024.
Paspasan mo ng iyong mapagpalang kamay.
Ang bawat alumni na buong pusong naglilingkod
At nag-aalay ng kanilang oras, talino, kakayahan.
Sama na ang mga nagbigay ng tulong pinansyal na hindi pa sa pinansyal. Upang maging maayos at mahusay ang aming pagdiriwang.
Pagpalain mo pa ang lahat ng kasapit ng UP Medical Alumni Society.
Pati na rin ang mga miyembro ng UP Medical Alumni Society in America.
Upang makatuguan ang lahat ng alumni sa pangangailangan.
Ng aming pinakamamahal na UP College of Medicine.
Ang lahat ng ito'y idinadalangin namin sa aming kagustuhan na ikaw ay papurihan, O Diyos, magpakailanman. Amen.
We would like to ask everyone to kindly turn off your microphone and video. Please type your questions in the Q&A chat box. We will try to address all of them in the open forum after the presentation. Evaluation and post-test questions will be available for 1 hour after the initial broadcast. A certificate of attendance will be emailed to you once the evaluation and post-test are completed.
Good afternoon, everyone. Magandang tanghali po sa lahat ng ating manunood at lubos ang aming pasasalamat sa inyong pagtangkilik sa aming proyekto na may pamagat na Bridging Gaps, the UPCM 1999 webinar series. This webinar is part of the UP Med webinar series of 2024 and is organized by our Silver Jubilarian class of 1999. So I am Dr. Cindy Hautan, a proud member of the University of the Philippines College of Medicine class of 1999. I'm a pediatric and adult dermatologist, a fellow of the Philippine Dermatological Society, and currently the president of the Pediatric Dermatology Society of the Philippines. I'm here on behalf of the class of 1999 UP Med Webinars team to moderate today's session. So our topic for this webinar is something many of our patients can relate to. Did you know that approximately 85% of adolescents aged 15 to 17 years old are actually affected by acne? And acne vulgaris is one of the most common skin conditions that afflict individuals of various ages, presenting heterogeneously amongst our patients. It can have a significant impact on the social, the psychological, and even the emotional functioning of these individuals. So together, let us now discuss the hows and the whys of this seemingly innocuous disease. Let's discuss what management approach we as physicians and medical practitioners should employ to address the challenges of acne care and improve the quality of life of our patients. So we encourage everyone in the audience to actively participate in our open forum later on after the lecture. And please type in your questions in the Q&A box even while the lecture is still ongoing. And now it is my pleasure and honor to introduce our speaker for today. We are actually very, very privileged to have a distinguished alumna of the UP College of Medicine from the class of 1996 as our speaker. She was an outstanding medical graduate from the UP College of Medicine. She completed her dermatology residency at the Skin and Cancer Foundation Incorporated and pursued fellowship training in immunodermatology at the New York University and dermatopathology in the University of Indiana School of Medicine. She's also the residency training officer of the Department of Dermatology at the Carino Memorial Medical Center. She currently serves as the section chief of dermatopathology, the unit in Makati Medical Center, and she's also a consultant in St. Luke's Medical Center, Quezon City. Presently, she's our very well-loved and inspiring Vice President of the Philippine Dermatological Society. And to discuss managing different types of acne across the lifespan, ladies and gentlemen, let us all give a warm welcome for Dr. Maria Jasmine Hamora.
Thank you so much, Cindy, for your kind introduction. I'm very happy to be here. Congratulations to UPCM Class 1999. It's a wonderful occasion to be here, and I wish you all the best. What a beautiful song, no? Congratulations, it's really touching. So I'm very happy to be here and to talk to all of you about acne. So
Thank you so much,
just
Jess. The
relax,
floor
sit
is all
back.
yours.
Thank you, Cindy. Okay, so I'm sure everyone is excited to talk about acne, right? So who doesn't have acne or who hasn't dealt with it in their lifetime? So let me just go through the different information about acne. Then later we can have a nice discussion, okay? Feel free to type in your questions in the chat box so that we can have a lively discussion later. As you know, acne is the most prevalent skin disorder, not just in pediatrics, but we're also seeing it more and more in adults. It affects about 40% of children age 8 to 10, about 85% of adolescents age 15 to 17, and generally it resolves after 20 years of age, although it affects about 20 to 40% of adults. And then later on, we'll talk about why that happens, okay? And it really happens in areas of high numbers of sebaceous glands, which are basically the forehead, the nose, and the chin, the T-zone of the face, the chest, and the upper back. Let's talk about the different kinds of lesions that we see in acne, okay? So when we see on the face, we can have different types of lesions. One is called the comedone. So the comedone is basically the hair follicle that either can be tightly closed or a little bit open so that the sebum gets oxidized. So this on the upper left-hand side is box A are called closed comedones. They're often called whiteheads by people. On the B, we have these blackheads or open comedones. And then here on the C, we see these inflammatory red papules. Some of them have white pus on the surface, and these are called pustules. And then on the right side, we have what we call cysts or even nodules. And sometimes these nodules, which are deep and quite painful, don't press them, okay? So for people, they like to make tiris or they like to poke these things. Don't do that because these have a large possibility of becoming scarring. So sometimes they can kind of clump together and become what's called pseudocysts. So acne can happen both in males and females, and the increased severity is often predicted by earlier onset. So if as the boy or girl undergoes puberty, when they have acne and it's earlier in onset, sometimes it predicts a worse severity later on. Okay, and even a positive family history of scarring acne. And also generally, acne is responsive to a lot of topicals, and we'll talk about this later, okay? So when we're saying mild acne, what we see is a few papules and pustules. Usually it is on less than half of the face. So if less than half of the face is involved in our patients, we can say that that's generally mild. Okay, so here we see some red papules on the face. It can even go up to the jaw and even on the neck area, mostly on the forehead. And these are pustules here with the white spots on them. Some open and closed comedones. When we say moderate, okay, it usually is more than half of the face involved, increasing number of lesions, both open and closed comedones, the inflammatory papules, the pustules, and you may see a few nodules, just a few, okay? So that's moderate. And then when you see almost all of the face involved, and you see a lot of these deep-seated kind of nodules and cysts, as well as pustules and inflammatory lesions, we call this severe, okay? So this is a kind of a simple way to grade whether you have mild, moderate, or severe acne. So take note that even the trunk can be involved, okay? The chest and the back, and that can be part of acne called truncal acne. These are some of the sequelae or some of the consequences or complications of acne. You can have these little what we call ice pick scars, okay? So why are they called ice pick scars? They're small, they're narrow, they're kind of deep, and it looks like they've been stabbed by an ice pick. On the C, we have what's known as rolling scars. So they're a bit more superficial, they're a bit broader, but these are both atrophic scarring caused by acne, all right? On the chest, we can see either hypertrophic small scars. Okay, some people call them, they can be small and white. Some people call them papular elastolysis. But on this particular patient on the B, he has keloids. Okay, so keloids are scars that are more severe than regular hypertrophic scars. They kind of extend beyond the border of the original site of trauma, okay, or the acne. Now, during the pandemic, a lot of us suffered from maskne, or what we call acne mechanica. As you see on the diagram on the lower right-hand side, regular hormonal acne or adolescent acne happens on the T-zone of the face. When we see this kind of O-shaped pattern involvement around the mouth, which is where the mask is, we call that, we have to consider maskne or acne mechanica, and we have to talk about, changing the mask to like a cloth mask with a surgical mask on top of that. And that's usually due to increased temperature and occlusion, causing fungus and bacteria to grow, okay? And we can also have contact dermatitis. Now, when we see kind of a U shape along the jawline and the chin, even on the neck, that's usually hormonal acne. And we'll talk a little bit about that later when we talk about adult acne. Okay, so there are no fixed classifications for acne. You can see here from the American Academy of Dermatology, depending on the papules, pustules, and nodules, mild, moderate, and severe. This classification down here is a little bit more based on numbers, but I think it's a bit unwieldy for clinical practice. So anyway, we talked about how to grade severity. I personally like to use this Leeds grading. It's an old grading system, but depending on how severe, so what I do is I show this to the patients, they kind of look in the mirror and then they grade themselves. So anything below the grade of 4 to 5 generally is amenable to topical treatments. Okay? But anything above 4, 5, and so on would usually require systemic therapy. Same thing for truncal acne. It also has a Leeds grading system, so we have to also keep that in mind. So let's talk briefly about acne pathogenesis. So there are 4 reasons why we have acne. One is really oil, okay? Sebaceous glands and lobules and hormones. So because during adolescence, the kids usually have this, the onset of estrogen, progesterone, testosterone, the hormonal activation, and it really triggers, these androgens trigger the sebaceous lobule to have more sebum secretion. Not only that, they also tend to clog the opening of the hair follicles, okay? So we call hyperkeratosis. So what happens is this hair follicle becomes a sack of oil, okay? Becomes a sack of oil, accumulates this keratin, and there can be a lot of bacteria growing in this sac, okay, which is Cutibacterium acnes. It used to be called Propionibacterium acnes. And sometimes when this hair follicle explodes, when it becomes so huge, it explodes and there's a lot of inflammation, okay? So 4 reasons. It's oil, it's the clogging of the pores, it's the Cutibacterium acnes, and it's also the inflammation. So those are the 4 targets for acne. When we look at the different things that are out there for acne, and this is an old study, evidence-based dermatology done in 2008, looking at really all the studies, we can see that the different kinds of medication have different roles to play. Okay, so benzoyl peroxide is good for keratinization. It's also good for, it's a good antibacterial. It also helps remove inflammation. For tretinoin and the other retinoids, it's good to remove the clogs from the surface. It's also, it can also have a little bit of antibiotic and anti-inflammatory use. For clindamycin and other topical antibiotics, these usually just target Cutibacterium acnes. Now, for the anti-androgens like spironolactone or the oral contraceptive pills, these usually affect the sex-binding hormone globulins, and therefore it affects sebum secretion. There are so many things on the market now, right? Like azelaic acid, niacinamide. Actually, our patients are already smart. No, they know how to treat themselves with alpha hydroxy acids, salicylic acid. So they're getting very, very savvy about it. So we also have to understand how to use these medications and why to use it. So for azelaic acid, it's good for follicular keratinization. It also has some anti-Cutibacterium effect and also anti-inflammatory effect. It also is a very nice medication for hyperpigmentation. For the oral tetracycline class antibiotics, Cutibacterium acne is also anti-inflammatory. For erythromycin, again, generally topical antibiotics have fallen out of favor because of the spread of antimicrobial resistance, so we have to be careful about using it. And isotretinoin, which is a vitamin A derivative, which is the most effective, especially for severe types of acne, targets sebum secretion by causing a permanent shrinkage of the oil glands. It removes the hyperkeratinization. The bacteria and fungus, they don't have any oil to eat, so they kind of die off. And the inflammation also gets addressed. So let's start with skin cleansers. Generally, we don't recommend beads or any kind of exfoliating cleansers. Just use really mild soap, okay? And then this synthetic detergents, which are non-soaps, which have a balanced pH, are also less irritating, so we can use that. And we move on to topical retinoids. So these are derivatives of vitamin A. They have nuclear effects and target RAR and RXR. They have effects on cell proliferation and differentiation, as well as keratinization and inflammation. And so these bind basically to the trans-retinoic acid and cis-retinoic and leads to heterodimer activation. And it promotes the DNA activation and the transcription of the genes, okay? So it promotes transcription for differentiation of the skin, for apoptosis, and also immune modulation. So it really works at the nuclear level. So what are topical retinoids, okay? You've heard of things like tretinoin, you've heard of things like adapalene, okay? You've heard of things like tazarotene, and there's a newer one called trifarotene, okay? These are all retinoids that are available. So for the oral kinds, isotretinoin is available, etretinate and acitretin are no longer available on the Philippine market. So early comedogenic acne has follicular obstruction due to this plugging, and so topical retinoids can be used both in inflammatory and non-inflammatory acne, okay? And you can use this in conjunction with both oral and topical antibiotics, not at the same time. You use it with either oral or topical antibiotics. Adapalene as a topical retinoid is probably the least irritating than the other retinoids, which is why in some countries it's even sold over the counter. Okay, so combination retinoid-based therapy is first line for acne. So this study, if you can see the slide on the right side, you can see a comparison between plain adapalene, which is a plain retinoid, compared to a topical combination of adapalene with either benzoyl peroxide or adapalene with clindamycin. And you can see that the reduction in acne lesions was more significant in the combination therapy than just plain adapalene therapy. And so when you're addressing mild acne, the combination regimens, fixed combination are very effective. Okay, so locally, we have the adapalene benzoyl combination. There's also the adapalene clindamycin combination, which is available. And in some areas, you might find the benzoyl peroxide and the clindamycin combination. We'll talk about that later, okay? So in general, retinoids are very effective for and first line for acne. However, when you use the combination of the retinoid with antimicrobial agent, it is very efficacious and actually shows superior efficacy in this fixed dose combination. Here's an example of a tretinoin clindamycin study done. You can see before and after 3 months. And here another study showing the combination of benzoyl peroxide and adapalene, which is blue. And then the green is plain adapalene, the yellow is plain benzoyl peroxide, and the other one is vehicle. So you can see the response rate for the combination therapy adapalene benzoyl peroxide is significantly higher compared to the other ones alone. Okay, again here, another study using clindamycin and adapalene, which is the blue line with the diamonds. You can see the value at week 12, the drop in the lesion counts, okay, of acne, compared to just plain clindamycin alone or just plain adapalene alone. Okay, so these combination therapies are very effective. And as well, once you reach maintenance therapy, retinoid therapy alone, very effective to target microcomedones, which you may not see under the skin, as well as visible lesions. So we do recommend that how you should use these retinoids is put a pea-sized amount on your finger. You kind of dot it on your whole face. I call it, and then just gently spread it on the whole face. Avoid the upper and lower eyelids, the corners of the eyes, nose, and mouth, because those tend to kind of peel and burn a little bit if the retinoid gets caught there. So this is the reason why we don't do spot therapy with retinoids. You must treat the whole face, okay? So that's for maintenance therapy. And this just shows that when you stop the retinoids, once the patient gets better, they tend to rebound, and which is why it's good to just keep them on a retinoid when they reach maintenance therapy. Let's move on to topical benzoyl peroxide. Benzoyl peroxide, super old school, a nice medication that we've had in the past. It is usually found in a lot of the over-the-counter acne treatments. It's quite safe. It has bactericidal activity against Cutibacterium acnes by producing free radicals that oxidize bacterial protein. So it is antibacterial in that way. It also has some keratolytic effects, and it also has some sebum regulating effects. So in mild to moderate acne, it can be a treatment of choice either alone or in combination. And we haven't found resistance to this. So we do recommend that instead of using topical antibiotics that you try benzoyl peroxide. The only problem is that it's quite irritating. It can cause hyperpigmentation and erythema, and it can discolor clothes. It can bleach the clothes. So we recommend that you be careful about application. So it is effective in mild to moderate acne. It may cause initial sensitization. It has similar activity to antibiotics against inflammatory lesions. And the combination treatments are more effective than antibiotics alone. So here you can see on the picture before and after 12 weeks, 2.5 benzoyl peroxide with adapalene combination was more efficacious than monotherapy alone. All right, as we've said before. Now, in the US and in other countries, they have topical dapsone. You know that this is an antibacterial from the sulfone family in a 5% formulation applied twice daily for mild to moderate acne. You can see it's quite effective, and it usually works by inhibiting neutrophil chemotaxis and limiting free radicals. So very effective in 12 weeks against vehicle. Salicylic acid is another old school medication that we use. So it is a beta hydroxy acid, an exfoliant and chemical irritant. So the 2% more effective in reducing all lesion types rather than vehicle. So we still can use salicylic acid, but just be careful because it can be quite irritating for some people. We already talked about azelaic acid. We said that it increased keratinocyte keratolysis. Okay, so it improves that. It also has anti-Cutibacterium effects. It also has anti-inflammatory effects. So this study showed that 20% azelaic acid at 5 to 6 months was equivalent or as effective as tretinoin, benzoyl peroxide, and oral tetracyclines. So topical antibiotics, these were studies on clindamycin and erythromycin, which had reduction in inflammatory lesion counts compared to vehicle. However, as I said, we want to be careful about the onset of antimicrobial resistance. And so we do recommend minimizing or not using topical antibiotics if possible. Systemic antibiotics, we reserve this for moderate to severe inflammatory acne in combination with topical retinoids and benzoyl peroxide. So the tetracycline class of antibiotics should be considered first line for moderate to severe acne. It works by inhibiting protein synthesis by binding the 30S subunit, and it does have anti-inflammatory effects in inhibiting chemotaxis and metalloproteinase activity. So for oral antibiotics, there were head-to-head studies done, tetracycline, minocycline, doxycycline, limecycline, and it just showed that no oral antibiotic was demonstrated to be superior to any other, and just consistent improvement in about 70 to 90% of individuals at 12 weeks. So for moderate to severe acne, we do recommend this as first line. So more effective against inflammatory lesions than non-inflammatory lesions. So we suggest that you add a combination of topical retinoid with benzoyl peroxide to reduce antimicrobial resistance. Now, when you're considering hormonal issues in women, you must always consider in patients with amenorrhea, irregular menstrual cycles, hirsutism, obesity, and severe recalcitrant acne, polycystic ovarian syndrome. This is due to an androgen excess state. So work with an OB-GYN for this. And I do recommend always working with a PDS board certified dermatologist if you're having issues with your acne patients. So indications for hormonal treatment for acne, if OCP is consideration for the patient, if they want to family plan, severe acne not improving with traditional anti-acne medications, severe premenstrual worsening of acne, later post-adolescent acne, comorbid PCOS, and hyperandrogenism. Okay, and we talked about that U-shaped, that hormonal acne. You might want to consider hormonal therapy for that. So in these studies, it showed comparing 6 combined oral contraceptive pills. They're effective in reducing both inflammatory and non-inflammatory facial acne lesions. So in 31 trials, all contraceptive pills reduce acne lesions, and they showed that these combinations, levonorgestrel and norethindrone, had better results for mild to moderate acne. Drospirenone, COC, appeared to be more effective than norgestimate or norgestrol acetate, okay, but less effective than cyproterone acetate. So we do have these combination of pills also locally on the market. Just make sure to always talk to your patient about smoking, breast nutrient cancer, family history, and so on, and history of clotting. So for oral isotretinoin, this is the best treatment for severe treatment-resistant acne. It's frequently treated with oral isotretinoin. it can decrease sebum production, and it also improves keratinization, it removes inflammation, and the Pityrosporum and Cutibacterium acnes actually also decrease because it has significant effects against these organisms. Okay, so the efficacy of systemic isotretinoin for severe cystic acne is very, very well demonstrated. So these are 5 RCTs, isotretinoin versus placebo. In all cases, isotretinoin at 0.5 milligram per kilogram per day, was found to be more effective therapy than any of its comparators. So anywhere from 0.1 milligram per kilogram to 2 milligram per kilogram total dose. All these doses resulted in significantly decreased number of lesions. It will address both facial and even truncal acne. So oral isotretinoin should be reserved for severe treatment-resistant acne due to potentially serious adverse side effects, including teratogenicity. I want to warn our audience that some of these medications are available on Shopee, on Lazada, and we don't know where they're from. They're not FDA approved. This is completely illegal sale of medications. And I do want everyone to be an advocate for isotretinoin because this medication is too good to be banned on the market because of irresponsible use by lay people and people who are giving it or to their friends. So look at the severe side effects that can happen with isotretinoin. Teratogenicity. If a patient is taking isotretinoin and gets pregnant, the baby will have severe brain, heart, and lung deformities, cheilitis, pruritus, dryness, conjunctivitis, hair fall, musculoskeletal aids, alopecia, fatigue, corneal opacities, disc disease. And in patients with diagnosed depression and suicide, it is very dangerous to give isotretinoin because it can, although it has been debunked that it causes suicide and depression, it may aggravate and trigger. Therefore, you need to work with your psychiatrist if the patient has been diagnosed with any mental health issues. So lots of side effects for this medication. I do warn people to work with your PDS board certified dermatologist to give isotretinoin. It should not be given left and right. It is a significant medication, very effective in the right hands, but can be dangerous in the wrong hands. So just briefly before we end, let's just talk about neonatal and pediatric acne. So when we talk about neonatal, it's from birth to 6 weeks, infantile 6 weeks to 1 year, mid-childhood 1 year to 7 years, pre-adolescent 7 to 12 years, and adolescent 12 to 19, and post-adolescent or adult acne above the age of 25 years. So you can see here, little baby, this is actually Cindy's field. I dare not step on her territory, but let's just go through it briefly, okay? Infants with facial acne, mid-childhood acne, pre-adolescent acne, adolescent, and adolescent acne. So in the neonatal stage, we know that this is due to the hormones that are just circulating in the baby. From the maternal side, it is self-limited and benign. Nothing needs to be done. It happens in about 20% of neonates, and so we just leave that alone. However, when you diagnose acne between the ages of 1 to 12 years old, this is mid-childhood to pre-adolescent acne, you might want to consider seeing a pediatrician or a pediatric dermatologist to rule out endocrinologic disease, any tumor or gonadal pathology, especially if it's severe. And if it's affecting the child with regards to mental health, you might want to refer to a psychiatrist and a pediatric dermatologist. Now, in the age of 12 to 19, after menarche, it's quite normal. But also watch out for severe mental health conditions. So here's some examples of comedonal acne and kind of more severe inflammatory acne, which is more common in adolescent types. There are many differentials. For both younger pediatric acne and adolescent acne, so keep these in mind. And there's a very intense algorithm. You can email me. I'd be happy to send you the journals for this. For the pediatric acne, there's an algorithm here, which we don't have time to go through. But as I said, work with your pediatrician and your pediatric dermatologist for this if you're dealing with pediatric acne. So for the mild pediatric acne, first line, again, benzoyl peroxide or topical retinoid, or you can go straight ahead to the topical combination therapy of benzoyl peroxide with an antibiotic or a retinoid with benzoyl peroxide, okay? And then if there's an adequate response, you can shift or change or think about combination therapies. For the moderate pediatric acne, you can start with a combination therapy of retinoid with benzoyl peroxide, or consider oral antibiotics. Now, you have to be careful with your tetracycline antibiotics because remember, before the age of 12, it can affect bone and teeth with some staining and effects on the joints as well. So I do recommend that you work with your pediatrician, pediatric dermatologist to, if the acne is not responsive to topical treatment. And then for severe pediatric acne, again, first line is combination therapy with or without an antibiotic, oral antibiotic, and topical retinoids, okay? For adolescents, it's kind of the same. Topical retinoids or benzoyl peroxide or both in a combination therapy. If it's moderate acne, you start off with combination therapy, then you might want to consider either oral antibiotic with it. And if it's severe, you start off with oral antibiotic with a combination therapy. And then if it doesn't work in about 3 months, you might want to consider oral isotretinoin. You can see that the level of evidence and strength of recommendations for most of the medications that we talked about are level A and B, and strength A and B, and level 1 to 2. So briefly about post-adolescent acne, this happens after 20 years of age in about 20 to 40% of adults. Usually in the last few decades, we've seen acne occurring in people from 20 to 26 years. However, in 2001, they saw that this was increasing to the age of 40. So about 41% of women aged 25 to 40 was suffering from this post-adolescent or adult acne. Okay, with a peak of about 45% of women between the age of 21 to 30 years old. So this is called persistent acne, persistent or late onset, and usually there's kind of this inflammatory form on the U. Remember, this kind of jawline, U-shaped acne is hormonal. And let's look at the triggers, okay? So this is very important. I want to talk to you about all of it. In this post-adolescent acne, the most common trigger was smoking. So when you have patients with post-adolescent acne, ask them if they smoke, because smoking is just incredibly pro-inflammatory. And let's talk about some of the triggers. It is appropriate for all levels of acne that we talk about these triggers now. Smoking, very pro-inflammatory, very bad for the gut. It causes a lot of gut leakiness. Personal history of acne in adolescents for these older women. Family history of acne. No previous pregnancies, insufficient sleep. So we see a lot of our kids and older people now sleeping 3-4 hours a day. I do recommend that everyone sleeps 7 to 8 hours a day to prevent this acne, okay? Because it's very pro-inflammatory and they're not able to kind of manage their acne if they're not sleeping enough. So talk to your patients about this. Office work, I don't know why that's a trigger for these adult patients with acne. Hirsutism, of course, you have to worry about polycystic ovarian system or some kind of hormonal issues. Work with your OB-gynecologist with this. Higher levels of psychological stress, right? But I used to think that stress was mumbo jumbo in acne, but actually you'll find that the stress as a trigger is huge because it activates this cortisol releasing hormone and it triggers this oiliness, okay, this lipogenesis of the sebocytes. So we have to talk to them about that. And we also talked to them about sugar, dairy, and high glycemic food. In the past, I didn't believe in food as a problem for acne, but nowadays there are so many studies coming out talking about milk, whey protein, so dairy in general, sugar, high glycemic foods, a lot of fast foods and junk food, even cup noodles and junk food, and Lay's, whatever we love to eat. Those are the triggers for acne. And so we do have to kind of be careful and avoid these. Instead, you have to encourage your patients to eat a lot of vegetables, fruit, and fish. So in general, a Mediterranean diet, a low glycemic diet, and avoiding sugar and dairy is very important in our patients at all levels. This is the summary recommendation from the Southeast Asian Acne Alliance study. There was a Filipino dermatologist in this study, and therefore, I do recommend that this is very appropriate for us. So in mild acne, topical retinoids, topical benzoyl peroxide, or a combination of both, or retinoid with topical antibiotics, okay, as first line. For the moderate, you start with oral antibiotics, any of them, with topical retinoids plus minus the benzoyl peroxide. And then for severe, they do recommend oral isotretinoin after a failed 6 to 8 week trial of oral antibiotics in combination with the topical retinoids and benzoyl peroxide. Okay, so again, just briefly running through this. Again, I would be happy if you just emailed me. I will send you the protocols and the journals so that you can refer to it for your practice. It's kind of similar. Very severe acne, you can see oral isotretinoin or oral antibiotics with fixed combination therapy here. And then finally, let's just talk a little bit about scarring. What is your risk of acne scarring? So here on the left side is low risk for scarring. On the right side, high risk for scarring. One of the reasons why you should refer to a PDS board certified dermatologist soonest, even for young kids, is because we know how to manage at all ages and we want to avoid scarring, right? Because this is not just physical scarring. We're talking about psychological and emotional scarring for our patients. And scarring is very difficult to treat. It's actually more difficult to treat than just doing early intervention therapy for acne. So it says here, if you have early acne-induced scars and have acne, you might be at risk for developing more scars. So these were some of the questions. What is your worst acne? Does your parent sibling have acne? How long have you had acne? And do you pick or squeeze your acne spots? So please do not pick or squeeze your acne spots. It is not good. Even though it's very popular on IG to see people squeezing out their own acne pimples, or they call it very satisfying, please do not recommend this to your patients, and don't do it yourselves, okay? Because we'll have to deal with the different kinds of scars, ice pick scars, rolling scars, box scars, keloids, and hypertrophic scars. And of course, the post-inflammatory hyperpigmentation. As brown people, we do have a lot of issues with hyperpigmentation, and therefore a lot of the medications that we talked about today, like retinoids, like azelaic acid, alpha hydroxy, and salicylic acid, are very effective for the hyperpigmentation as well. Don't forget sunscreen, one of the most important, an SPF 50 or higher in the appropriate levels would be effective for these. Okay, so thank you very much for your kind attention. I'm sorry I ran a bit long, but we're open for your questions. Thank you very much.
Wow, thank you so much, Jazz, for
Yeah.
that very comprehensive, very insightful talk with lots and lots of learning points. And I'm very sure that our audience would also agree that, acne is just not a simple disease, and that management should really be focused on medical management. It should also be individualized. There's no one size fits all for our patients, and it's really important to seek consult with a board certified dermatologist. No? So at this point, we'd like to thank our sponsor, just very briefly, a very generous batchmate who wants to remain anonymous. Thank you so much for supporting our webinar. No? So again, we encourage our audience to type in and actively participate in our open forum. We actually have a number of questions already, Jazz, in the box.
Sure.
So for our members in the Zoom room, you can actually type it in the Q&A box. For those in the FB Live and UP Manila live stream, you can actually put your questions in the comment sections. Okay, so I think it's very important to start with the terminologies first, Jazz. There are a few questions about proper terms, like what is the difference between acne and pimple, and what does it mean to have actually acne-prone skin? Yeah.
So I think pimples is kind of like just the general term, the lay term for acne. So it's kind of encompassing all the different types of lesions, right? So pimples, it's acceptable. Acne in a more medical sense, I think it encompasses all of that sin. So acne-prone skin, I think you're talking about maybe oily skin or super sebaceous skin, skin that is kind of very oily. I think those are kind of the acne-prone skin.
That's right. So oily skin with lots of those
How about you,
bigger
Sins? What do you
oil
think?
glands. I agree. I totally agree with you. So there are some acne,
That's
pimple.
right.
We usually use them interchangeably when we're explaining to patients, no? But we really need to, like you mentioned, we have to classify them as to having mild, moderate, severe, and the inflammatory versus non-inflammatory. So I think there are also a lot of questions about misconceptions about acne, particularly with regards to triggers. And you adequately discussed this in your slides. So there are questions about eating chocolate as triggers, and whether it's important to have a specific diet for acne patients. Yeah.
Yeah. So since people hate to be on a diet, right? We hate to give diets.
Right.
But in general, if they're serious about treating their acne and avoiding flares, I do say sugar and dairy. Especially like a lot of people love milk tea. It's a combination of both sugar and dairy. So if you're gonna go to a milk tea place, get just the tea, no milk, and then put a sugar substitute or no sugar. You can have your milk tea, but without the milk and without the sugar. Chocolate, because it is both dairy and sugar, can trigger some people, since not everyone. And the reason for this, because it kind of works through what they call the mTORC pathway. There are some pro-inflammatory pathways that are sensitive to the whey. It's the leucine in the protein. Like even red meats can trigger that pathway. And so if you are sensitive to that, especially in acne, then just avoid it. Challenge yourself to do an 8-week test. So 2 months, no sugar, no dairy, see how your skin is. Then after 2 months, eat as much sugar and dairy and junk food as you want and see what happens. So let's see. Let's just challenge and then see what happens. So let's see if you're sensitive.
That's right. Yeah, I agree. Totally. No, before we didn't think that diet really played a very big role in terms of acne, but with the recent studies that have been coming out, we now have more updates, no, with regards to the triggers in terms of food. So there's also a question here about the role of azelaic acid in a patient taking isotretinoin. I think you also mentioned this. Is it safe to use azelaic acid for patients undergoing acne trex treatment or isotretinoin for that matter?
Yeah, it's safe. It's safe, except I would just recommend when you're taking isotretinoin, your skin will get dry and kind of sensitive and peeling. So everything that's an acid will be a bit irritating for your face. So retinoin is retinoic acid, salicylic acid, alpha hydroxy acid, azelaic acid. Anything that says acid will be irritating for your face. So just be careful. Once you start to feel stinging, burning, just stop it. Talk to your dermatologist and see if you can just, stop it or if you need another medication.
Yeah, I'm
Thank you.
actually glad that you brought up that issue about selling of medications online. Yeah, it's a really good time to warn our patients and colleagues that they should not be, buying their medications online and to seek consult first before they start any medication. So there's also
Yeah.
a question here. I think it's more of a case, no? A patient who is actually what can you suggest for preteens starting to have acne with mother with PCOS or PCOS? And the teen is high risk for PCOS as well. Do you
Okay.
advise hormonal pills at an early age?
Uh, no, I don't. So I always work with an OB-GYN. I always refer, no, if I suspect something, I'll refer to the pediatrician if it's a child or the OB-GYN if it's an adult and, let them sort out the hormonal issues. I can do some hormonal tests initially, but for the child, I don't know since how young you would go for retinoids. But if it's like a child, like maybe 12 or so, you can start with maybe adapalene. It's okay. The mild retinoids might be okay at a certain age. I don't know since how early do you start on retinoids for kids with acne?
Are you talking about topical retinoids or oral retinoids? Like,
Just topical retinoids. I would never give oral retinoids at a pediatric age. Yeah.
yeah, so for topical retinoids, it depends on the patient. So usually you have your comedonal acne coming during your pre-adolescent stage. So for those, we can give our second or third generation retinoids like your adapalene that would be less irritating. We can give them at between 7 to 8 years old when they start getting all these, pre-adolescent acne. But we also need to be careful because we need to advise them as to what to actually, expect, right? Like you mentioned, you can get retinoid dermatitis, you can get, some bit of peeling and scaling. So we really need to be able to talk to our patients and, discuss our treatment plan with them, right? So yeah, I think it's very important that we know what the population that we're dealing with, because not all patients with acne would be treated the same way, right? Yeah.
Right.
So
Exactly.
there are also a lot of questions here about post-acne scarring and pigmentation. So is there an
Sure.
effective way to manage your scarring and pigmentation? Yeah. So
Right. Yeah. So see your PDS board certified dermatologist to deal with the scars, no? Because some people refer to pigmentation as scars. Some people
yes.
refer to the parang lubog as scars, which is the atrophic scars. And then there's also the bumpy scars. So
Mm,
there are broad, categories of treatment for these kinds of scars. It can be procedural, right? So you can do maybe subcision,
mm,
fillers, whatever. There's so many things that can be done. Fractionated resurfacing for scars. I do suggest you see a PDS board certified dermatologist for either the atrophic or the hypertrophic scars. For the pigmentation, we already talked about sunscreen. We talked
that's right.
about some of the things that are already available on the market for like the retinoids, like the alpha hydroxy acid and things like that. There's even niacinamide, which is available over the counter, which is good both for acne and also for the pigmentation. So there's a bunch of different things that you can use. There's so many things on the market right now.
Yeah.
Go
So
ahead.
speaking of sunscreen, there's a question from our FB live portion. What is a good sunscreen for patients with acne-prone skin, especially with the recent issue about global warming? I'm not exactly sure what this was, but they're asking about a good sunscreen for acne-prone
Okay.
skin. Yeah.
Okay, so try to find an SPF 50 sunscreen if you're going outdoors. If you're indoors, maybe 30 is okay. But if you're acne prone, if you're very oily, you want to go for kind of a liquid or a gel sunscreen. Okay. Now, if you kind of have dry skin, you want to go for more of a creamy type or of a lotion type sunscreen. I don't want to recommend any brands, just go to your local drugstore. You'll see a lot of sunscreens there. And try to find something that is fragrance free, that is hypoallergenic, that has an SPF 50 and above, that has broad spectrum, which means it protects both against UVA, UVB, and visible light.
Yeah, I totally agree. Yeah. So, and also there's a question here about the perennial question of how many times you need to wash your face when you have acne. That's always a question that is asked of us.
Yeah. So I do suggest wash your face twice a day with soap, okay? With a soap. Because sometimes you're washing just with a non-soap cleanser. Wash your face occasionally with a soap. So twice a day is actually more than enough. Don't scrub, don't use the beads, especially if you have a lot of acne, if you have sensitive skin. You know what? Since what I'm finding is people aren't shampooing anymore. I do suggest, especially if you have
Okay.
oily scalp, shampoo every day. Yeah, there's some kind of trends happening that they're not really shampooing their scalp as well. So soap your
Okay.
face twice a day. Doesn't have to be more. Twice, I think. Don't over soap as well, because it can be
Right.
irritating drying out your face. Yeah.
Yeah. So we advise them to just wash gently, no,
Yeah.
using a soapy
Yeah.
cleanser,
Mild soap.
like you
Mild soap.
mentioned. Yeah. So there are a lot of cases that are, being posted here in our Q&A box. I'll just take one of them. One doctor or medical colleague is saying that they're currently taking isotretinoin, 20 milligrams, advised to take it for a year, but when they stopped, it came back. Is it
Uh-huh.
possible? Yeah.
Yeah, for sure it can come back. So isotretinoin, there's a broad range of therapeutic for what we call cure, no? Or kind of long-term remission of
Right.
acne. So in the first course, if you're doing it at about 120 milligram per kilogram total dose, which what you're
Mm-hmm.
doing for about a year, it's about a 60 to 80% chance of permanent cure of remission. But that means to say there's about 20 to 40% of people who would still need either a higher dose of isotretinoin or just a longer duration. So again, just work with your PDS board certified dermatologist for this kind of treatment.
Yes, I agree. It's also case to case basis, right, Jazz? So we need to
Yes,
really see the
absolutely.
patient, do a very thorough history and
Absolutely.
physical
Mhm.
examination, no? Just to make sure that there's nothing else ongoing,
Yeah, you
no?
don't want to miss any hormonal issues since you don't want to
Exactly.
miss anything like they're
Yes.
taking
Yeah.
medications that can trigger acne. Maybe they're putting
Right.
steroids in the face. I mean, there's a bunch of
Mm-mm.
different things happen.
Exactly,
Yeah.
yes. With sometimes it's the sale of products is not regulated, so they just tend to
Right.
put things on their skin without
Yeah.
proper medical
Yeah, you know
advice,
what I'm
right?
seeing since? Can I just have a public service announcement
Yes,
here?
yes,
A lot of
exactly.
our patients are, doing Korean glass skin trending. And
Yes.
they're putting so many products on their face and super
Mm.
oily, kind of greasy.
Mm.
Remember that Korea is a four-season place. It's cold. They have winter, and we're a tropical climate. So our skin can't really take all these greasy, oily products. Okay,
Mm-hmm.
yes,
Mm-hmm.
we want glass skin, but sometimes you're putting oil upon oil, and
Mm-mm.
it clog your pores. So we're seeing a lot of acne cosmetica, actually, acne mechanica, triggers of acne. So just really be careful about what you're putting on your skin. Just because it's available doesn't mean it's the best thing for your skin. Okay?
Yes, exactly. I totally agree. So 10 steps does not actually
Yeah.
work for us in a very tropical climate
Right.
country, right? So yeah, we
Right.
usually advise our patients to keep it simple. Just stick to the
Right.
necessities. Yeah.
Clean. Yeah.
Yeah.
Just clean your face, put your meds, put sunscreen.
Yeah,
That's
that's right. So there's also a question here about rejuvenating sets. I think that's also an issue that we
oh,
face day to day with our
a
patients,
lot.
right?
A lot. A
So
lot.
they come to us with irritant
Yeah.
contact dermatitis from all these products. What's your comment on this?
So rejuvenating sets can come from a lot of different people. Some of them may be doctors, some of them may not be doctors. I want you to be careful. Some of them might have steroids. Some of them might have very, very strong medicines like hydroquinone, which should be regulated and should be just monitored by a dermatologist. So if you see that your face is super red, like peeling, like burned, don't just stop it.
Mm.
Okay. If it's not hiyang or you're breaking out more than usual, I do suggest that you stop it and just see. As we talked about, you don't need that much for
Mm-hmm.
acne. You only need what? One or two things.
Yes.
Wash your face and put the medicine, and that's
Mm-hmm.
really it. And then you should be okay. Yeah, so just be careful. That's all I want to say.
Yes, exactly. So, just a few more questions before we close the open forum, no, Jazz? So, there's a question here about what is the proper moisturizing, what is a proper soap for acne? Is it safe to use papaya soap for teenagers with oily skin? And what is the difference between chemical sunscreen? Is it safe versus physical sunscreen? Like you mentioned, our patients are very learned now. They have a
Yeah,
lot.
yeah,
They come to us
very.
with lots of information, right?
Yeah,
So
absolutely.
and
Very
they're
smart.
very aware.
Yeah, very
Yeah.
smart. Let's take the first question first. So, with regards to soap, if you have just regular combination skin, a mild soap, synthetic detergent type soap, which is, hypoallergenic, fragrance free, just really mild. Baby soaps, you can use to wash your face. Okay, it doesn't have to be fancy. If you're very, very oily, there are some glycolic or salicylic acid soaps on the market. You can try it. If it doesn't irritate you, it's fine. You can get that in your drugstore, okay? Now, with regards to papaya soap is actually very effective because it causes barrier breakage, meaning to say it'll peel the skin. If you're interested in peeling the skin, it's fine. But for teenagers and for people with sensitive skin, I do advise not to use the papaya soap, okay? So if you're very, very oily or like you can tolerate the papaya soap, it's fine. But I generally, for sensitive skin, for acne prone skin, I don't recommend it, right? Talk to your dermatologist about it, okay? Because it's quite effective in peeling and causing barrier breakage. And we've seen that in studies as well using papaya soap, okay? Yeah.
I agree.
Thank you.
Yes, I agree. Yes, thank you so much for that, Jazz. So there is a question here. I guess I just wanted to also address this question because it hits a spot. So acne treatment, one of our participants actually mentioned that acne treatment is quite a challenge. Most of the prescribed soaps, lotions, and medicines are expensive. Are there alternatives that we can buy from leading supermarkets and drugstores? I think we need to really parang dispel the myth that acne treatment is expensive, right, Jazz? Yeah.
Right. It doesn't have to be expensive. There are medications on the market, and I think in my lecture I had given you the generic names for the treatment for that. So you are able to get at your drugstore these adapalene, clindamycin, benzoyl peroxide combinations. It's quite reasonable and you can avail of it. Oral antibiotics doesn't have to be expensive. Doxycycline is easily available. It doesn't have to be expensive. So, work with your PDS board certified dermatologist to find medications that you can use quite reasonably for your patients that are available locally. In the drugstores and in the market, maybe I would go for maybe more of the cleansers and the sunscreens when you want to buy in the groceries or in the drugstores, or maybe even the soaps. But I think when it comes to medication, you really want to work with your dermatologist or your pediatric dermatologist to try to find the best treatments for your patients. And let's always talk about budget, right? Always talk to your patients about it. Bring it up with your doctors if you're a patient, and just tell them, this is my budget, doc. What can we do with this? Okay? So don't go crazy. It doesn't have to be expensive. There's a lot of things on the market available that we can reasonably do to get you to your best optimal skin. Thanks.
Yes, thank you so much, Jazz, for really enlightening us with your expertise, your experience. It has been a very fun, interactive, open forum. We unfortunately we don't have time for all the questions in the box, and hopefully there'll be a part two. Who knows, right? So, but yes, in the PDS we have our advocacies of making sure that we keep our patients informed of the proper management of these conditions. And I hope that with this, we are able to inform our colleagues that they need to seek medical help for acne vulgaris or for other dermatologic conditions for that matter. No? So thank you so much, Jazz. So in summary, I just wanted to highlight 3 points that we talked about this afternoon. That acne is a very important dermatologic condition. It has a very significant impact, high burden of disease, right? So it can actually have affect the quality of life of our patients, and that medical management is really warranted. So early intervention is important. Responsible management and medical management is also important. No. So we should always try to prevent acne and not just treat when they're there. So thank you so much, Jazz, our dear speaker, for taking the time and generally sharing your expertise with us despite your very, very busy schedule. The UPCM class of 1999 is very, very grateful for your acceptance to this invitation. We'd like to present the certificate of appreciation. It reads the University of the Philippines College of Medicine and the UPCM Postgraduate Institute of Medicine and the UP College of Medicine class of 1999 present the certificate of appreciation to Maria Jasmine Hamora for sharing her expertise as speaker in the UP Medicine Webinars 2024 lecture entitled Managing Different Types of Acne Across the Lifespan, held on this day, 7th of February 2024 via virtual platform. Signed by our class president, Dr. Carlo Panelo, and the director of the Postgraduate Institute of Medicine, Dr. Teresa Cruz. Thank you so much, Jazz. It has been a pleasure and an
Congratulations,
honor.
Cindy
Thank you
and
so
Cynthia
much.
God bless you
Thank
all. Have a
you.
good year.
Thank you so
Bye.
much. We also would like to thank our audience for tuning in today. We appreciate your active participation in our lively discussion and open forum. We'd like to request for you to stay for some more reminders. No? So we'd also like to thank the UP College of Medicine, the Postgraduate Institute of Medicine, and the UP Medical Alumni Society, as well as the UP Manila Information Management Service for their support for this webinar series. No? And again, thank you to our classmate who generously donated for this to sponsor this webinar. And we would also like to acknowledge our certificates partner for this webinar, Experto. Thank you very much. No? So we'd like to invite everyone to also join us for our Lenten webinar scheduled for Friday, February 16 from 12 noon to 1 p.m. Our lecturer will be Father Gregory Ramon Gaston, who is the rector of the Pontificio Colegio Filipino in Rome, Italy. So this webinar is co-organized by the UPCM classes of 1990 and 1999. For those who want to get a certificate of attendance, kindly answer the evaluation form within the next hour. You can access the link through the QR code that is posted here on the slide, or you can also use the URL posted in the chat box. Thank you so much to all our attendees. Okay? And we'd like to greet you a very good afternoon.
Wow, thank you naman at nakaikot tayo dito. Ang ganda ng lugar.
No, ang ganda talaga makikita. Ngayon na tayo nakapasok.
Mas na-appreciate ko siya kasi the first time I was here, maraming tao.
During the inauguration,
Yes.
no? I think this was inaugurated noong September 20.
Yeah.
Tama?
Eh, ano yung January daw?
Parang soft opening yan.
So
Yes, the open is, tapos pero yung formal inauguration happened.
ayaw may piya kayo tayo na yung September.
Yeah, wala tayong idea na yung class project pala natin ganito kaganda.
Yeah.
Kasi we contributed to this.
At least ganito, no? You know where your money went.
Tsaka napakaganda kasi it's something na hindi natin na-experience.
This is something new, groundbreaking for the
Innovative. I mean, it's a new way of teaching, so it challenges us, the faculty, also to learn at the same time, so be learners also with our students.
Paano ba tayo natuto ng skills? Sige nga, paano?
Sa tao na sa
See one, do one, and teach one.
Sa actual person.
Yeah.
Samantalang dito, pwede na nilang practicein yung skills sa mga mannequins na ang gaganda.
So yung refinement, yung like techniques, yeah.
So lesser
Very
ang
nice.
possibility of injuries.
Morbidity.
Kaya nga, nung nalaman ko na pang clinical simulation lab yung project natin, I was really very happy na it turns out na napakaganda ng makakontribute natin sa college.
Alright, so Leonard, we came from the OR setup, no? So here, we're the task trainers room where students can practice already the different procedures like IV insertion, breast examination, blood extraction, and also pelvic exam and catheterization.
May circumcision din.
Ayun, nandun yung circumcision.
O di ba?
Yeah.
Nahirapan ka nga dun sa retroverted, ano?
Yeah, nung tinry ko kanina, muntik pa ako mapala.
So yeah, so aside from that, there's also a childbirth sim area where patients can, let's go over there.
Okay. Ito yung favorite room ko out of all the simulation rooms kasi this is the OB room. And ito si Lucina, the model for the normal delivery, right? At ito yung baby niya. May pangalan ba yung baby niya?
Wala, Lucina, baby. Ito, anak
Bigger.
Ang galing, no? The students can actually
Gumagalaw ang patara yan.
They can actually simulate childbirth dito. No?
Yeah.
And all the other drills.
All the maneuvers, like shoulder dystocia, do vacuum extraction,
Breech delivery.
Yeah.
So for both normal and abnormal situations, emergency.
Yeah, so they'll ask the professors, the doctors to to give a scenario that they want simulated. So they also have modules for postpartum hemorrhage, for uterine atony and uterine inversion. So yeah.
Tapos yung SimTech, i-input nila yan dun sa computer. Tapos yun ang gagawin ng
Kailangan the consultant should be very detailed para alam ng mga bata kung how to approach these emergencies or whatever.
Pero kahit face-to-face tayo ngayon, mas magandang dito na muna magsimula, di ba? Para parang magaling na sila pagpunta nila sa PGH.
May skills kung dati sa PGH.
Equate with the skills.
True.
Hindi natin to magagawa without the help of our classmates
True.
who generously gave to this project. Even if we have the slightest idea of what the thing we're supporting was at the time, diba? And moving, as you said, from that medicine building to the Henry C. Medical Sciences Center and to the CSL finally. And we look forward to celebrating with the rest of our classmates for our homecoming this year, and celebrating also this achievement of being able to help and give back to the college. Maraming salamat.